thank you very much. Sorry, I have to actually lower the mic here, so I'm not. So it gives me great pleasure to be here and talk to you about neuroendocrine tumors. So I was given the task of talking about neuroendocrine neoplasm, sort of the broad overview, the 30,000-foot view over this. So I could stand here all day and talk about it, but I was only given 30 minutes, 35 actually, which is plenty. We'll make it through. So let's. So these are my disclosures. So. And let's just move into the objectives. So what I hope to do here is to talk about the neuroendocrine neoplasms, or NENs, or NETs, how common they are, what are the symptoms, and sort of briefly talk about how we diagnose or work someone up. And then why we need medical oncologists like myself, why this has to be a multidisciplinary treatment, and then talk about the multidisciplinary teams per se. So what are NENs or NETs? So neuroendocrine neoplasms or neuroendocrine tumors are a group of tumors that can really arise anywhere. So what I wanted to talk to you a little bit this slide is that the nomenclature, the naming of these things are changing. So, or they're not called NETs anymore. Well, NETs is only a part of the big family of NENs. So if you wanted, neuroendocrine neoplasm is a term that captures all of these tumors, and NETs are the most common part of it. So what is then the difference between a NET and a NEN? So neoplasm is really an abnormal mass of tissue that is growing and is not, the cells are dividing when they shouldn't, and or not dying when they should. And the definition of a tumor is essentially the same. But for neuroendocrine neoplasms, it's a little different, because in that context, tumor and neoplasm are not necessarily the same thing. It sounds a little complicated. We'll go through it. I'll walk you through it. And so what are NETs? So these are cancers. I think we need to be honest, and we need to talk about these as cancers. A lot of people have been told that they have benign tumors, and only a minority of them are benign. These are truly cancers. They have the capacity to invade other organs and spread to other organs. And they most commonly happen in the gastrointestinal tract, lungs, so small intestines, pancreas, and rectum. But they can really arise anywhere. I don't think there is an organ that is free of the risk of having neuroendocrine tumors. I've seen neuroendocrine tumors in pretty much every organ in the body. So they are extremely heterogeneous in the sense that we don't. In a sense that no two neuroendocrine tumor patients are the same. So when you meet someone who has a neuroendocrine tumor, and the odds are that that person has a very different neuroendocrine tumor than the one that you have. And we'll go into that a little bit more. So the behavior of the NETs varies greatly from one person to the next. That's why it's so hard when you discuss this with other people with neuroendocrine tumors. There are all of these differences among different patients that sort of dictate how this tumor will behave over the months or the years. So these can be among the slowest growing tumors that you find in humans, and tumors that may never ever need to be treated. And in fact, actually, a lot of people probably have them without ever knowing. There was a study, a very fascinating study from Japan many years ago, that looked at patients who died of old age in a nursing home, and they had an autopsy that looked at their pancreas. And they found that 10% of these people dying in this particular nursing home who had this kind of an autopsy had small pancreatic neuroendocrine tumors. None of them knew that they had it during the lifetime. So they are probably much more common than we think. And so grade 1 tumors, I sometimes show this picture to patients. They are slow growing generally, and then we have the grade 3 tumors, which are moving much faster. But they are on a spectrum, so it's not like all grade 3 tumors move really fast and all grade 1 tumors move really slow. And we'll talk about tumor grade here a little bit. So this is the busy. I promise this is the busiest slide I will have and I will test you at the end of the talk on this. So really what I wanted to show you here, this is the 2019 classification of neuroendocrine tumors. So this just came out last month or the month before that. So the WHO, or World Health Organization, puts together these big sort of meetings with people, experts, and they sort of hash out what should be, how should we define neuroendocrine tumors, how should we call them, how should we classify them, because we, as scientists, we want to classify everything. And so really what I wanted to show here, and let's see if I can make this, oh, sorry. again. So I'm not sure if I have a pointer here, but anyway. So if so essentially these are three different grades and actually 5 different classes of neuroendocrine tumors, and then a mixed. So perfect. So really, we have these 3 different grades, grade 1, grade 2, grade 3, but then we have these large cell, small cell, and we have the differentiation. And really the important thing here when we grade them is to look at what's called the Ki-67 index and the mitotic count. And I'll show you slides of each. So moving on, so tumor grade. So this is really a system for us to predict how a tumor will behave over time. It's not a perfect system, but it's actually not bad either. So what we do is that we take a special tissue stain and we apply it to slides of tissue, and then we count the number of cells that stain positive. So these are the cells that are actively replicating or dividing, and the stain should not stain cells that are resting. And this tumor grade, just purely the number of cells that stain positive, will fairly accurately predict how the tumor will behave over the next months to years. So more dividing cells, more aggressive NETs, or NENs. So this is how it looks to the pathologist. So if you look at this here on the left-hand side, so this is a grade 1 tumor, less than 3% of the cells stain positive. You see that there are occasional little brown dots here. So this is fairly easy for us to call. And then grade 2, you can see that now up to 20% of them can be positive. So you can see that still a minority of them are dividing or replicating. You see all of those faint blue dots here. These are resting cells. They are not doing anything. They're just sitting there. And a grade 3, sometimes you can see that all of the cells are actively dividing. So those tend to be the most aggressive tumors. And this is all done, we're mostly done sort of computerized now. We just take the slide, we stick it into a digital reader, and it just scans the slide and spits out a number, which is much faster and probably much more accurate than sitting there and counting them just manually. So, but not all grade 3 tumors are the same. We'll get into that a little bit more later. But so here we have grade 1, grade 2, grade 3. And the grade 3 tumors are very, very different from one person to the next. We can have a very slow-growing grade 3 tumor, and we can have a very fast-growing grade 3 tumor. We can almost never see a fast-growing grade 1 tumor. So the well-differentiated, and that's where we get into the differentiation. That's the next slide. So the well-differentiated grade 3 neuroendocrine tumors, they probably for most parts behave like grade 2 neuroendocrine tumors. They move a little bit faster, but not much. And the poorly differentiated grade 3 neuroendocrine tumors, these move extremely fast. And these are among the most aggressive tumors we'll see in humans, and they need immediate therapy, usually with a combination of chemotherapy, possibly with immunotherapy, which we'll maybe hear about a little bit later today. So the problem here is that we still need an expert pathologist to look at these. So the grade 3 tumors, I told you the grade is designed is assigned by a computer that reads the slides, but we still need a pathologist to look in the microscope and tell us what is the differentiation of this tumor. And that requires an expert pathologist, and this is something that people get wrong all the time. So last week, actually this week, I was in the clinic and I saw someone who was referred to me as a pancreatic adenocarcinoma and referred for chemotherapy essentially. And we reread that as grade 1 neuroendocrine tumor. So it means that the pathologist who read the initial slide got it completely wrong. Not only did he get the grade wrong, but he actually got the tumor type wrong. And so these things happen. These can happen to any good pathologist if you have just having a bad day and you're reading these slides, or if you're not then a very experienced pathologist. So you really need a good pathologist to look at this. Okay, differentiation. This is the concept I have the most difficulty explaining. So this differentiation really means how much do the tumor cells look like the cell of origin that they started. But the problem is that we don't know always what was the cell of origin. So really what we're looking at here is how aggressive, how angry looking are these tumors. And so the well-differentiated tumor cells, they tend to be all of the same size, very similar shapes, and they all look the same. The poorly differentiated tumors are all like different shapes and sizes. Some of them are dying, others look very different. So instead of showing the cells, what I sometimes say, this would be the well-differentiated tumor, and this would be the poorly differentiated tumor. So you can actually see that when you look in the microscope, as one of my pathologists said, these are the cells that you don't want to meet in a dark alley at night. And so you can really tell. But then it gets a little bit more complicated because we have these grade 3 tumors, which are here, but not all of them are poorly differentiated. But all poorly differentiated tumors are grade 3. So it's getting a little complicated, and that's why actually we need neuroendocrine tumor specialists and pathologists to do this. So, grade and differentiation. Hopefully I didn't make it more complicated than it should be, but let's move on to the next important thing that determines prognosis. So we look at grade, differentiation, and stage. And so these are the cancer stages. So stage 0 is something we almost never see in neuroendocrine tumors. Stage 1 are localized tumors. Stage 2 are more advanced, and then up to stage 4. So how does that really look in the body? So let's move on to the next slide here. So this is for colon cancer, but the same rules apply. So here we have stage 1 or 2. So these are tumors here, in this case, limited to the colon, and they may either be just on the inside of the colon, or they may start growing through the wall of the colon, but they haven't really gone anywhere beyond that. Stage 3, now we can see the green things here, these green vessels or lumps here outside of the colon. These are the lymph nodes. Now we can see that the tumor has gone from where it started in the colon into the lymph nodes. So this would be stage 3. And then stage 4 is really when the tumor, which started in the colon or in the small bowel or in the pancreas, has gone to the liver or gone to the lungs or bones or other organs. So that would be stage 4. So there are only these 5 stages essentially, but stage 0 is something we really don't talk about because we don't really see that. So is this really a problem? So or how big of a problem are NETs? So actually they turn out to be quite a big of a problem. So these numbers are rising. So for all neuroendocrine tumors, we expect to see 7 per 100,000 per year. So in a city like Rochester, which has about 100,000 people, we would expect to see 7 cases a year. So I'm horrible at math. So I looked up the population of Illinois, and I came up with a number close to 900 cases in Illinois per year. And but take that with a grain of salt, though. And so these are the most common origins, so lung, small bowel, pancreas, rectum, appendix. And what I wanted to show you here is that this curve here is the number of all cancers in the US. This goes down back to 1973, and here we are at 2012. And you can see that in the 70s and the 80s, the number of all cancers started going up, and then actually started to go down. And the reason for the number of cancers going down is that we're screening for colon cancer and people are not smoking as much. But now we might actually see a little bit of an uptick again, possibly because of obesity. And if you look at the next curve, these are the NETs. So you can see that they have continued to increase. So we're diagnosing more and more and more. So you can see that from the early 70s until now, there has been about 6-fold increase in the number of new neuroendocrine tumor diagnoses. So we think some of this is actually from just better diagnostics. We have better scans. People are getting more scans. But I think there's also a real increase. And how does this look for different neuroendocrine tumor types? So if we look at the lung, you can see that there has been a steady increase in the number of new lung cancer neuroendocrine tumors, or lung neuroendocrine tumors. And this, I think, is largely due to more use of cross-sectional imaging, CT scans, and such. And for the small intestines, a steady increase. That's the small bowel NETs, the most common NETs. And then for the pancreas down here, really not much of a change until very recently, where we've seen a very noticeable uptick in the number of new cases. And we actually just shown, and we have a paper pending showing that in the last 15 years, there has been a 3-fold increase in the number of new pancreatic neuroendocrine tumor cases diagnosed, possibly largely due to more imaging. So what are the symptoms of neuroendocrine tumors? So they can be very nonspecific, as many of you know, and sometimes just a little bit of diarrhea, a little bit of flushing occasionally, and then different neuroendocrine tumors have different presenting features. Some are actually very quiet and don't cause any symptoms. Others cause symptoms from bulky tumors that are causing pain. And then they can make stuff. They can make hormones, or they can make serotonin that make you sick. So just a few of the symptoms from the tumor itself. So we have these obstructive symptoms, so crampy abdominal pain. This is a common symptom of small bowel neuroendocrine tumor. Jaundice from biliary obstruction, sometimes seen with pancreatic neuroendocrine tumors. Cough or recurrent pneumonia, always in the same part of the lung with the lung neuroendocrine tumors. Sometimes blood in the stools, coughing up blood. pain, things of that nature. And then non-specific symptoms, just not feeling unwell, losing weight, those kinds of things. So carcinoid syndrome, so this is a syndrome that's something we see in the small bowel neuroendocrine tumors. So this is usually caused by production of chemicals such as serotonin that result in symptoms such as diarrhea and flushing. So the diarrhea is generally caused by serotonin. The flushing is not caused by serotonin. That's caused by some other chemicals that these tumors make. If you take someone and you give them IV infusion of serotonin, they will have diarrhea, but they may not flush. And then these are sometimes worsened by alcohol, exercise, emotional upset, that sort of stuff. And then these, with time, can actually damage the heart valves. I'll show you some pictures of that as well. So as for the pancreatic neuroendocrine tumors, they can make stuff like insulin. It can drop your blood sugar. It can make gastrin, which can cause stomach ulcers, and that's called Zollinger-Ellison syndrome. Just yesterday, I saw a patient with a classic Zollinger-Ellison syndrome, had been going to doctors mostly for diarrhea, but then started having these stomach ulcers, and sort of no one really put all of these things together. And then when we saw her, obviously gastroenterology had made the diagnosis. It all seemed crystal clear to us. But if one symptom happens, like it's mild, and then there's another symptom that comes on top of that, it's just hard sometimes for us to see the big picture. It's always very easy for us in the ivory towers to say, this should have been seen years ago. But if you're the primary care doctor taking care of these patients, it's actually remarkably hard to make these diagnoses. So let's move on here. So this here I wanted to show you. So let's first take a look at the left-hand side. So this is a typical carcinoid flush. I got this from a Canadian medical journal. So this flushing of the skin here, the face. And what I wanted to show you, if we could play that video clip here on the right-hand side. If we just go back one slide. Sorry, we'll go. You can see here, see those veins here that are, this is a patient I saw a few months ago. You can see those pulsating veins. So I was just examining this person, and he had a neuroendocrine tumor, and I was thinking, well, this isn't right. So he had carcinoid heart disease, and these are the symptoms or signs that you can see if you really carefully examine patients. So let's move on to the next slide. So here I need some help from tech, and let's start this one. So this is the carcinoid heart disease. You can see here are the liver tumors making the serotonin, which is flowing into the bloodstream, into the heart, and you can see the heart valves, how they get thicker and stiffer, and instead of moving freely, they're like moving sluggishly, and they're not closing. So now the heart valves on the right side start leaking and causing increased pressure that causes these veins to bulge, and then all sorts of other symptoms like swelling of the legs and shortness of breath, and so on and so forth. So moving on. So these tumors can sometimes cause skin rash. This is a patient with glucagonoma who had the characteristic skin rash. And this is another one who had a characteristic skin rash of the legs, were started on octreotide, and the skin rash cleared up. So this is something we see very rarely, but we see it occasionally. Okay, so how do we make this diagnosis of NETs? So it's a team effort. So we need the pathology, we need the radiology, other specialties, gastroenterology, clinical chemistry, pulmonary medicine, surgery, endocrinology. So this really is a team effort. It's a challenging diagnosis to make. So tumor markers, I know that a lot of people are interested in tumor markers. So here's my short take. 2 slides on tumor markers. Generally, they are not very helpful, with some exceptions though. So 5-HIAA in patients with carcinoid syndrome is helpful. And they are helpful to monitor treatment activity, but in terms of making the diagnosis for most patients with neuroendocrine tumors, tumor markers are not helpful. And there is no perfect marker, and markers should almost never be used to determine therapy. So just a quick slide here on chromogranin. So I'm not going to read all of this to you. These are all of the things that can elevate chromogranin that are not neuroendocrine tumors and are not cancer. These are all of the things like medications that can elevate chromogranin. These are all of the other cancers that can elevate chromogranin. So this is just not a good test. And so it, although it does have some correlation with how long people may live, it doesn't really help us diagnose, and it doesn't really help to determine who should get what therapy. So if the test is providing very little value, should we really be ordering it? So tumor imaging, this is really the exciting stuff for us in neuroendocrine oncology because these things have changed a lot over the years. So we have CT, which is probably the workhorse in our clinic. That's the study we use the most. MRIs, PETs, and I was just going to show you a few things here. So this is a patient I saw 2 weeks ago, 3 weeks ago. Okay, let's see if it, okay, so this is a CT. You can see that there's a tumor in the liver. This is an octrea scan done at the same time. There's nothing. This is an MRI done the following week. We can see liver lesions. This is a fused gallium-68 dotatate PET MRI, and we're picking up a lot of lesions. These octrea scan, these are done like a couple of weeks apart. So to me, and we've known this, octrea scans served us well, but octrea scans should be pronounced dead. And they have served us well, but we have just moved on. We have much better imaging than octrea scans. So what about regular PETs? So a lot of people come in and say, well, my doctor did a PET and they didn't really find anything. Well, the regular PET is what's called an FDG PET. So that looks at tumor metabolism. Look, we're giving you radioactive sugar that the tumor cells gobble up, and then we take a picture of the body and we see where it went. So this is a patient with a low-grade neuroendocrine tumor. This is a regular PET. There is really not much going on. This is a dotatate PET. Lots of tumors in the liver. There's the primary tumor. Not seen on the regular PET. Here it is again. And this is the regular PET CT. You can see there is really not much going on in this liver. Here is the dotatate PET. Every month, I probably see 2 or 3 patients with a low-grade neuroendocrine tumor who come in with an FDG PET CT. For a low-grade neuroendocrine tumor, that is a near. It's not a useless test, but it's a very limited utility. It's incredibly important for high-grade neuroendocrine tumors. So I'm not saying we should never do it, but you just have to pick those imaging studies very carefully. Okay, so moving on. So why do we need better drug therapy? That's because of patients like this. One of my patients had a lot of tumors from a PNET. Not even Dr. Howe could, I think, remove all of these tumors, although possibly. So we treated with chemotherapy in this instance. And this is another patient who was referred to me for a few liver metastases and for consideration of surgery. Indeed, there are some liver metastases here, but these are all bone metastases. So this person, instead of coming in for surgery, actually went home on medical therapy with injections. Actually happens to be doing just fine 2 or 3 years later and on octreotide or lanreotide. So I'm going to skip over this one here, just in the interest of time, and talk a little bit about the main concepts of therapy. Does anyone or everyone with a neuroendocrine tumor need to be treated? Absolutely no. So we definitely observe a lot of patients. I have a number of patients now on observation. They come in every 3 to 6 months, and they have never seen therapy yet. We have a biopsy-proven grade 1 neuroendocrine tumor, and we're just watching. So treatment consideration, so why do we treat? So we treat to relieve symptoms of the carcinoid syndrome, hormonal pancreatic neuroendocrine tumors, or symptoms from bulky tumors or metastases. So that's one thing. So we treat to make people feel better. We also treat to make people live longer, and that's to prolong survival. But keep in mind that not all treatments have been shown to prolong survival, and some treatments are toxic, they're painful, they have side effects, and they have what we call now financial toxicity, which many of you may be aware of. These are not cheap drugs, and they may not always be completely covered. So we have to be mindful of that. Does the patient need to be treated? What should we treat them with? And so on and so forth. Don't forget that every person is unique, so this is not like a one-size-fits-all. So we have that's the reason for the multidisciplinary teams. So things to consider before starting therapy. So is treatment really needed? Are there troublesome symptoms? Is there rapid tumor growth? And then where did this neuroendocrine tumor start? Because a pancreatic tumor is treated very differently from a small bowel neuroendocrine tumor. And then what's the stage? And then obviously the grade and the differentiation. So the team approach is incredibly important, and there is generally, with the exception of high-grade, poorly differentiated neuroendocrine carcinomas, there's no rush in starting therapy. So we usually have time to get all of the team together and discuss these. And it's better to get these NET experts involved early. So that's why we have tumor boards. So tumor boards are meetings which can be, so occasionally like virtual, can be most often in person. You have a lot of different specialties: surgery, oncology, radiology, nuclear medicine, interventional radiology, pathology, gastroenterology, genetics, and we sit together and we discuss how we should treat patients. And why do we do this? We do this because we think that more brain power, more CPU is better. So having more brains together is better. And then also the initial approach may change. And it's been shown scientifically that medical oncologists are really bad about predicting if patients may be candidates for surgery or not. This has actually been scientifically shown that we are just not good at saying who are the patients who should have surgery. And then sometimes there are several reasonable approaches, and then we have to go back to the patient and say, well, these are the options we have. Which one fits your goals? And even we have to consider, there are financial things we have to consider. And then probably most importantly for a lot of our patients, especially those who travel from afar, we can actually, in a tumor board, we can get 30 different specialties to take a look at the case without the patient having to come in for 30 different visits. So that may be one visit, case presented at the tumor board, I call the patient with a plan. So we are making it to the end, so I won't talk too much about the treatment other than just treatment of symptoms, which are somatostatin analogs, and then all sorts of symptoms we have for diarrhea and so on and so forth. We'll hear a lot more of that later today. So as for the anti-tumor therapy, this is going to be my last slide. So there's a lot of options we have for anti-tumor therapy. That's what the rest of the day is for. And the subsequent speakers will really talk about that. So I decided not to go into all of those details. So that brings me to the end. So thank you very much for listening, and gladly take some questions.